Hi everyone, this is Julie Breen with the Toothy Tutor, and I'm here in the first of a series of local anesthesia preparatory coursework. If you like this content, please subscribe to my channel, follow me on Instagram, or check out my Stan store where I have much more free materials, practice quizzes, and case studies. So infiltration, we spoke a little bit in class that as hygienists, we don't use infiltration very much because we tend to work in sextants or quadrants. So infiltration is useful for the maxilla because the bone is very porous and it allows the anesthetic to penetrate very easily through the bone. The mandible's bone is much more dense, so it's difficult to use infiltration for the mandible and have it be successful. Occasionally, for mandibular anesthesia, the anterior teeth, the central incisors, will have some cross innervation of nerves from the other side, so you may infiltrate at the area of the central incisors to get all the way to the midline after delivering an inferior alveolar nerve block. But infiltration can be useful in the maxilla. It's less useful in the mandible, but occasionally we do use it. So you want to deliver the anesthetic at the apex of the tooth to be anesthetized. It's usually a 3 to 6 millimeter penetration depth with a one plane aspiration. And you'll be delivering about 1/4 to half a cartridge for infiltration. Now the anterior superior alveolar nerve block, or ASA, the needle we use there is a 27 short. And the reason we can use the 27 short, the 27, that's the middle lumen diameter, the area is not very vascular. We're not going very deep, so we're not worried about a lot of deflection. So the 27 is ideal for this injection. And we can also use a short needle because we're not going very deep. And in fact, we only go about 4 to 6 millimeters. There's a one plane aspiration, and the reason we use the one plane aspiration with the ASA is it's not a very vascular area. And our anatomical landmark is the canine eminence. So what's getting numb? Pulp, buccal periosteum, connective tissue, mucous membrane of the maxillary central incisor through the canine on the injected side. And you'll be delivering between 1/2 and 2/3 of a cartridge to achieve adequate anesthesia for the ASA. Now, troubleshooting. Inadequate anesthesia. This can happen for several reasons. One of the reasons is you didn't penetrate deep enough. You didn't get to the apex of the canine. Another reason why you may have inadequate anesthesia is because you didn't deliver enough anesthetic. You really need to get that 1/2 to 2/3 of a cartridge. Think of a cup filled with water. When you spill a cup out, it's sort of the water will fan out. And when we're injecting this liquid, underneath the tissue, it fans out. Some of the molecules are moving towards the nerve, and some of the molecules are moving away from the nerve. So we need to inject enough molecules to get anesthesia. Now, if you've given a right ASA and the patient is complaining that only the mesial of number 8 is still sensitive, what may be the case there is there's cross innervation from the contralateral side. That can also happen. Additionally, if you've given 2 ASAs and the centrals stay, the patient is still complaining both centrals are very sensitive, sometimes that can be because the nasopalatine nerve is actually innervating the pulps of 8 and 9. That's rare. Usually, if the patient is feeling something over the central, that may be a good indication to do an additional infiltration over tooth number 8 to get that mesial surface. Some local complications These would be very rare that you would get a hematoma, especially an external hematoma from an ASA. You may get a tiny internal hematoma after an ASA. Tissue sloughing can happen, especially if you're twirling the cotton-tipped applicator with a topical anesthetic. Some systemic complications, toxicity or overdose reactions, we avoid those by doing a nice slow deposition, and we're aspirating very carefully so that we are not inside a vessel. Now let's look at the middle superior alveolar nerve block. Again, 27 short. Why? Pretty much for the same reasons, if not all the same reasons, that we can use it for the anterior superior alveolar nerve block. We're not going very deep, so we're not that concerned about deflection. It's not a very vascular area. So we're going a little bit deeper here, about 5 to 8 millimeters. And the one plane aspiration is because the area is not very vascular. And our anatomical landmark for the MSA nerve block is the second premolar. You will be parallel to the long axis of the second premolar and insert the needle 5 to 8 millimeters. And what's getting numb? 28% of the population has a middle superior alveolar nerve. So in patients that have the MSA nerve, 28% of the population, I think in your reading it said anywhere between 28 and 50%. Malamed at different textbooks says 28%. The pulp, buccal periosteum, connective tissue, mucous membrane of the maxillary first and second premolars, and the mesial buccal root of the first molar. And we'll be delivering here a 1/2 to 2/3 of a cartridge. So you may wonder, do I have an MSA? It sometimes can be difficult to tell